Oh, okay. I'll send him a text.
Yeah.
He should be here. I think he's usually here. Thank you, Rishi, for joining today.
Thank you very much, sir.
My pleasure, yeah.
Yes.
Are we expecting Dr. Gulia, sir?
Sir, he didn't say. He said he will try, but
Okay.
we can start at 5:30.
Okay. I mean,
Yeah.
okay.
Since we have a few things to discuss, we'll start on
Okay.
time.
All right, I don't mind.
Yeah. Sir, has this been circulated in the AIMS group? And yeah. And ऋषिराम जी आपके ग्रुप में आपने शेयर किया था?
हाँ मैंने शेयर किया था और रेजिडेंट लोगों को और ये लोगों को।
ओके।
एक्चुअली हमारे यहाँ पे नेपाल में एक और प्रोग्राम था, एक ऑर्थोपेडिक्स का बाई मंथली मीट था।
ओके।
पीपल हैव जॉइंड, आई थिंक ऑर्थोपेडिक्स ने सर्जरी का कुछ था कुछ शायद।
ओके, यूजुअली आते हैं आप नेपाल में से काफी लोग ज्वाइन
करते हैं या our residents and our friends actually they join. I can see few my residents and colleagues are there.
Yeah.
Dr. Pratik? Dr. Pratik, can you hear me? Hello?
Dr. Venkatesan sir, we can hear you. Dr. Pratik sir is in phone, sir. We'll just connect you.
Okay. So there is some issues for Dr. Lau Kapoor to join, it seems. If you guys can help him, that will be very good.
Okay, sir. I'll just convey to Dr. Pratik sir.
Okay, thank you. Who is this? Mr. Banerjee. Nice to meet you.
From Intas, sir.
Oh.
Mr. Banerjee, I think उनको एक लिंक भेजना पड़ेगा Mr. Love Kapoor को. I'll do that, है ना? So In the meanwhile, it is 5:30, so I think we'll start, and then background I'll help Dr. Love Kapoor to join. So if Dr. Venkatesan says okay, we'll go ahead.
Yeah, we can start. You can start the introduction, Dr. Sir.
Yes. So welcome all to this April session of Nurture the Future. This, as we all know, was meant for the postgraduate students and young orthopedic consultants to just hone their orthopedic oncology knowledge. And we have now presently had finished 8 sessions, and now this is the 9th session, and this one is specifically targeted for PG students on case presentations. So our chairman for today is Dr. Ajay Puri. Unfortunately, he's not able to join us as he's traveling, but we are joined today by the moderator, Dr. Venkatesan Sampath Kumar. Now, before we go ahead with the program, I would just like to introduce him. Dr. Venkatesan did his MBBS from Madras Medical College and then progressed on to do his MS Orthopedics from AIIMS Hospital, New Delhi. After that, he did his Commonwealth Orthopedic Oncology Fellowship from the famous Robert Jones and Agnes Hunt Hospital in UK, which was the first dedicated orthopedic hospital in the UK. He also went on to do his lower limb arthroplasty fellowship from the famous Wrightington Hospital, where Sir John Chanley practiced and developed the hip arthroplasty that we all have following now. He has also finished his fellowship in Royal College of Surgery in Trauma and Orthopedics, and right now is an assistant professor at AIIMS. Sir has decided to pursue and progress his musculoskeletal oncology knowledge and is currently doing a traveling fellowship, I would say, in Memorial Small Kettering, a cancer center in New York. And that is where Sir is joining us from. So thank you, Sir, for taking time and moderating this session. I think I'll hand over this to you to take it forward. Thank you.
Thank you, Dr. Pradeep, for a kind introduction. So, good evening, everyone. At the outset, I would like to thank the Sarcoma Education Foundation team for giving me this opportunity, especially Professor Ashish Gulia sir and Dr. Pratik Hegde has done a lot of hard work to getting this meeting scheduled and arranged for today. Thank you, Dr. Pratik, for all the hard work you did. I'd also like to thank Professor Ajay Puri sir, although he has not been able to join us in the meeting today. He has sent his blessings. And my faculty for this evening, along with Dr. Pratik, will also include Dr. Hegde, Dr. Love Kapoor, and Dr. Rishi Podal. So Dr. Love Kapoor is an orthopedic oncologist specializing in bone and soft tissue tumors. He did his medical education and residency training at Government Medical College Hospital, Chandigarh. Then he did a fellowship with us at AIIMS Delhi. His research interests include the development of new surgical techniques and therapies for musculoskeletal tumors, and he has published several articles in peer-reviewed journals and presented at national and international conferences. You all know Dr. Pratik. He got trained in orthopedic oncology at Tata Memorial Hospital and is now practicing as an orthopedic oncosurgeon in Mumbai and Navi Mumbai. He's very dynamic. And next we move on to Dr. Rishi. He completed his undergraduation as well as MS Orthopedics from AIIMS Delhi. After completing his orthopedic oncology training from AIIMS Delhi, he moved on to University of Malaya, Malaysia, to train for a year in orthopedic oncology. And then subsequently, he did one more fellowship with Max Hospital in Saket, New Delhi. He's currently serving in his own country, Nepal, as Assistant Professor Orthopedic Oncology at Patan Academy of Health Sciences at Lalitpur, Nepal. He's one of the founder members of Musculoskeletal Oncology Societies of Nepal and Team SOC Nepal. Most importantly, I would also like to thank Dr. Nitish, who is a fellow currently at Tata Memorial Hospital. He has kindly agreed to present a case at a very short notice. And with this introduction, I would like to move on to the session today. All right. Can you all see my screen?
Yes, sir, it's visible. You might have to make it full screen.
So, Yeah. So see, this will be like a case presentation series where I would like to take you through all the common questions which I have encountered both as a postgraduate student while preparing for my exam, and also I've been involved in postgraduate exit exams at AIIMS Delhi. During my senior residency, I was involved in conducting those exams. And then once I moved on to become a faculty member, I have been involved on the side of the examiners, examining these postgraduate scenarios. And with my experience, I've tried to collect all the important questions that a postgraduate will be asked during his exam. So the primary discussion for today will be focused on the exit exam for orthopedics. But at the same time, we have also tried to include scenarios and discussions that will help the general orthopedic surgeons if time permits, depending upon how we do. There is no time pressure here. I would encourage all of you to participate. If anyone has any questions, please feel free to post it in the chat box, and Dr. Pratik, or somebody from the Sarcoma Education Foundation team, if they can bring those questions, we can discuss. It is very important to learn these points rather than like just hear it and forget about it. Okay, so let's start. So at the outset, I would like to thank my teachers, Professor Shishi Rastogi sir and Professor Shah Alam Khan sir. They have taught me all I know in oncology. So whenever we think of a bone tumor case, it is usually a short case. We don't keep bone tumors as long case in the PG exam. So a short case typically has 4 questions. So what is your diagnosis? Why do you say so? What else can it be? And how will you manage this patient? Okay. So it's a very, very common mistake that people forget to mention the side of the tumor. People forget to mention what is the name of the bone which is involved, whether it's a tibia or femur. So be sure that you get all these basic things right. Okay. So as a student, you always think about advanced things, what will be the management, what will be the discussion. But as an examiner, we always think about basics, very fundamental things, which anybody can pass with the common knowledge. So all these fundamental tick boxes has to be kept in mind. Okay. And the second question, why do you say so? Then people will start talking about everything like, so in the history we had this, in the examination we had this, there was no scar, no sinuses, no fungation. So this question, why do you say so, needs a bit of thinking. You must understand that we should give out only relevant, positive positive history and examination findings, which can help you in arrive at your diagnosis. Okay. So always in bone tumors, you cannot have a confirmed diagnosis based just on clinical examination. Even radiological investigations like MRI won't be enough to make the diagnosis. The final word always comes from the pathologist. And I'll also take you through the problems even pathology faces sometimes in arriving at the diagnosis. So when you have a case, don't say, sir, what is the diagnosis? Sir, this is GCT left distal femur. No, this is not what we want to hear, because if you say the diagnosis, it means that somebody has helped you in giving you the diagnosis. No clinician can be 100% sure about a germ cell tumor just by inspection and palpation and movements and measurements. We have to have additional information for this. Okay. So always think, whenever somebody asks you, like, what else can it be? You say, sir, germ cell tumor is my first differential diagnosis, but I have other things in mind, which can be a differential diagnosis. Okay. Other important problem is when you give your differential diagnosis, you say, first, it's a germ cell tumor. The second diagnosis, osteochondroma. Third diagnosis, osteosarcoma. This is not a proper differential set. The reason is, on one side, you are giving osteochondroma, which is a benign tumor, as a differential. The other side, you are giving osteosarcoma, which is a malignant tumor, as a differential. So germ cell tumors are a little bit tricky because they can be very locally aggressive, and it is very difficult to put them in a basket like a benign or malignant. But at the same time, the overall clinical picture will lead you either to a benign diagnosis or to a malignant diagnosis. So depending upon how the overall picture is leading you, you have to give GCT versus an osteosarcoma or a GCT versus an osteochondroma. But you cannot give both the benign and malignant differential diagnosis into the same case. Then it will feel as if you do not understand what is the difference between a benign and a malignancy. So you must understand the reason why a bone tumor case is kept for the exam. Number one, it is a swelling case. Okay, so the basic ESDAS workup of how to inspect and palpate the swelling will apply for a bone tumor. Okay, so that's what the examiner wants you to understand. And what at the end of that examination, all they want you to differentiate is between a benign swelling and a malignant swelling, possibly based upon your clinical judgment. Okay, so how will you manage this patient? Please don't just say the treatment. Please start with the staging workup. Please start with laboratory investigations and radiological investigations before jumping onto biopsy. Always talk about CT chest or a bone scan or PET scan, whichever you think is appropriate. Okay, I'm not going to give you a cookbook recipe of this. If this is the question, this is the answer. But this is very important that you go through all these things. So at the end of my lecture today, I would share my email link with you. So if any of you are interested in getting this presentation, I'll be happy to share as well. So you can just concentrate on the presentation. Okay. So how to clinically differentiate a benign and malignant bone tumor? Okay, you said you want us to differentiate. How are you going to differentiate? Okay. So there are multiple cues that can happen, but in my mind, I would say that differentiation is not based on a single history or a single exam finding, except for one particular history, which is very, very important, which is definitely pointing towards malignant. I will let you know that, which is again basic. I would keep it in my mind. I'm looking for like 5 points in history, 3 points in my general examination, 5 points in inspection, 5 points in palpation, and 2 other points. Okay, what are these? So in the history, I'm looking at this table, slightly busy table, but this is what you are supposed to keep in mind. Talk about symptom onset, whether it is a swelling followed by pain or whether it's a pain followed by swelling. For most benign tumors like osteochondromas or GCTs, it is usually the swelling which comes first, followed by pain. But for malignant tumors like osteosarcomas, the onset of pain is usually present before the swelling. Remember, the patient will always attribute the pain to a traumatic incident. We have known by experience and by publications that trauma cannot directly lead to an osteosarcoma, but it brings the patient to pay attention to that site. So most of the times patient would say, oh, I had an injury to the knee and then I noticed the swelling. Okay, so that doesn't mean that the trauma gave rise to the swelling. Only after that injury, he started appreciating that he has a swelling in the bone. Okay, and the duration in a benign tumor can vary from months to years. And in a malignant swelling, it's usually from weeks to months with a rapid progression in the size of the swelling. A patient is able to use the body part in which the tumor is located with or without difficulty in a benign swelling. But in a malignant swelling, especially when it is advanced in its presentation, there is usually a loss of function. Okay. Symptoms suggestive of metastasis are usually absent in a benign swelling, but they may be present in a malignant swelling. So what are the symptoms suggestive of metastasis? We are talking about like chest symptoms. Patient has cough, patient has hemoptysis, patient has breathlessness, patient has lumps in the inguinal region, and a patient who has a swelling in the distal femur. These are the symptoms which can suggest metastasis. And also patient has fever, patient has loss of weight, patient has loss of appetite. These are all important history that the patient has got a systemic involvement rather than just a local involvement. And then history of chemotherapy. Remember, this is a very important history. So most of the times when you get a patient of osteosarcoma in the case, the patient is already under treatment because we do not want a malignant tumor to wait for the exam to finish. So whenever there is a history of chemotherapy, and if there is a good response to chemotherapy, the swelling size might reduce and the swelling may start to behave like a benign swelling. But at the same time, if there is a history of chemotherapy that is present, that is a telltale sign that this is a malignant swelling, because I do not know of a benign swelling where we can give chemotherapy in today's era. All right. So of all the different history, if you have history of chemotherapy, that is very pathognomonic. Okay. On examination, we need to ask for like 3 different examination in general examination. So findings of cachexia, like patient is ill-built, poorly nourished, pale, loss of hair, and findings suggestive of metastasis such as pleural effusion, swellings in multiple body sites, or deformed forearms. So deformed forearms is very important to check, especially in a case with osteochondromas. Most of you will know that osteochondroma can have a hereditary multiple exhastosis kind of a presentation, where the patient is usually younger, patient has swelling at multiple body sites, and patient also has deformity in the forearm, typically described by Masada et al. And they have given different types of these deformities and the different ways to treat. So if you have an osteochondroma case, and if you have not examined the forearm for any deformities or loss of pronosupination movements, then it can be a big mistake. It can be, you could have missed a hereditary multiple exhastosis for a solitary benign osteochondroma, which makes a huge difference. Why? See, the MS orthopedic exams is focused on safety. All we are trying to ask is like, it's like getting a driving license. When you pass a driving license test, the most important thing they want to ensure is you're safe to other drivers on the road. Similarly, we want to ensure that you're safe and you do not miss a patient of hereditary multiple exhastosis with a benign osteochondroma, because HME has higher incidence of conversion to a malignant chondrosarcoma or other sarcomas compared to a benign osteochondroma. So if you do not pick it up, it is a big mistake in terms of safety for the patient. And similarly, even during the clinical exam, all we are trying to see is whether you can differentiate a benign or a malignant swelling. Okay. And what are the 5 points in infection that I am thinking it's in favor of a malignant swelling? Skin is stretched and shiny. You can have dilated veins. You can have an irregular surface. You can have wasting of the limb, and you can have ulcerations or fungations. Okay. So if you look at the picture to your right, you can see that on the medial side of the proximal tibia, there is an ulceration. On the lateral side, there is a fungation. Okay. Ulceration is. I would request all of you to mute yourself if you're hearing this lecture, so that others do not get any interruption. Thank you very much. So all these factors are in favor of a malignant swelling. So what are the palpatory findings I'm thinking in my mind? The temperature may be raised in a malignant swelling. The tenderness will be significant in a malignant swelling. The margins will be ill-defined or imperceptible in a malignant swelling. The consistency can be variable in a malignant swelling. Variable means it's usually not soft, it's firm to hard. And the skin can be adhered to the swelling. That is, the skin is involved by the swelling. Okay. So all these things are very important in the sense there are certain buzzwords or commonly accepted terminologies that you have to talk about. Okay. In a clinical examination, you should talk about margins. You should not talk about borders. And the word we accept is whether it's well-defined or ill-defined or imperceptible. And the consistency, you have to be either soft, firm, or hard. Usually, the tumors for the orthopedic exam are firm, hard, or variable consistency. Hard tumors are like bony tumors, like osteochondromas. Firm can be a tumor which has got a soft tissue component, will behave like a firm malignancy. And when you look at the fixity to the skin, you should also try to involve or assess whether the tumor is above the muscle or below the muscle. How do you do that? You try to contract that particular area where the swelling is there. For example, if you have a tumor on the anterior aspect of distal femur, you should try to put the quadriceps muscle into contraction and see if the swelling is getting prominent. If it gets prominent, it means the tumor is above the muscle or the deep fascia, which is very rare. Most of the times, we have bony swellings which are kept in the exam. So the tumor either remains the same size if it is involving the muscle, or the tumor slightly becomes less appreciable once the muscle is put into contraction. So the other important points in the local examination, joint mobility and distal neurovascular deficit. And most important thing, which is not mentioned here, is feeling for the proximal lymph nodes. Okay. So you did this exam, you arrived based upon your history and examination findings. You say, oh, doctor, this is a malignant, probably a malignant tumor of the distal femur. So the examiner will ask you, can you feel the soft tissue component? You will say, yes, I can feel a soft tissue component on the lateral aspect of the thigh. Then they will ask you, is this a soft tissue tumor that is attaching to the bone, or is it a bony tumor that is producing a soft tissue component? Okay. Again, it is not 100% possible, but there are certain clinical cues which you should be able to pick it up to differentiate it. One, in both the above conditions, the swelling will be immobile and attached to the underlying bone. However, a primary bone malignancy will be continuous with the bone when you palpate along the edges of the swelling. So all you have to do is run your finger from top to bottom like this. And when you run your finger, if the swelling is continuous with the bone, it is most probably a bony swelling giving rise to a soft tissue component. Remember, what we are talking here is like a malignant swelling. Say, for example, if this was a pedunculated osteochondroma arising out of distal femur, you will feel that there is a small depression between the swelling and the native bone. So this is called ability to get over the top of the swelling. Okay. So if you tell the examiner, I'm able to insinuate my finger between the swelling and the bone, or I'm able to get over the top of the swelling, then it is again a pathognomonic or more or less 95% surety that this is going to be an osteochondroma. Okay. And the second thing, when a bone tumor puts out a soft tissue, it is usually not limited to one compartment. For example, in the thigh, if you palpate very closely, you will feel that the soft tissue component arising out of a distal femur osteosarcoma, can be present both medially, anteriorly, sometimes even posteriorly. Okay, so if you have more than one compartment that's involved by the soft tissue component, when you run your finger along the longitudinal axis of the bone, then it's most probably a bone tumor coming out of soft tissue. If a soft tissue tumor were to attach to the bone, then it is usually limited to one single compartment. Okay, either the extensor compartment or the flexor compartment of the thigh in this particular example. Okay, so apart from the clinical findings, when you look at the X-ray again, there are small clues by which you can pick up this differentiation. Okay, and it is very important to know that. Okay, so what is this? So like how you have an earthquake, the swelling can be marked or bound. You can mark the boundary of the swelling and put an epicenter on the center where you think is the center of the mass. Okay. So although this is not 100% perfect, because sometimes you can have irregular shaped mass where it's hard to put an epicenter. But if the epicenter falls outside the bone or outside the cortex, it might be a soft tissue tumor coming into the bone, and rather than if the epicenter is falling inside the bone. The second thing we can think about is if you follow the bevel of the cortex. Okay. Let me see if I can get. I don't think. All right. So if you follow the bevel of the cortex here, if the cortex is beveled towards the inside of the medullary cavity of the bone, it is probably a soft tissue tumor invading the bone. Whereas if there's a bony tumor coming into the soft tissue, the cortex is usually beveled outside like this towards the skin or the extremity. And the third thing you know is periosteal reaction. Obviously, when the periosteum is lifted, the inner cambium layer of the periosteum contains resting stem cells, which can, mesenchymal stem cells, which can get activated and differentiate into osteoblast, and they can start applying new bone. Okay. So when the periosteum is lifted, it can be, it is usually a bone tumor coming out of the soft tissues or into the soft tissues. Whereas if there is no periosteal reaction, it is possibly the soft tissue tumor getting into the bone. Okay. So this kind of a periosteal reaction can happen in both malignant tumors like osteosarcomas as well as benign tumor, as well as Ewing sarcomas, but they have different classically described periosteal reaction. For example, Ewing sarcoma is supposed to get an onion skin type of a periosteal reaction, but let me caution you, we have found that from time and again, even osteosarcomas, and it has been described and published in the books and literature, that osteosarcoma can also have a periosteal reaction, which is kind of an onion skinning, whereas the Codman triangle can be found in other conditions also, which is typically described in osteosarcoma. Incidentally, the Codman angle was described in Boston, Harvard, Massachusetts. So that's one another important thing. And we can go into a discussion later on why this happens, like why it is not pathognomonic, but it all relates to the consistency of the material. If you, in most tumors like Ewing sarcomas, it is a round blue cell tumor. So the consistency of the tumor is predominantly fluid or semi-solid. So they raise the periosteum, form a periosteal reaction, and then they puncture through the periosteum and they have another layer. Sometimes osteosarcoma can have majority of necrotic mass and they can create a similar picture. Whereas Codman angle means like there is more solid component coming out of this into the soft tissues. Okay, so for you, for the exam, the examiner wants you to know that Ewing's is onion skin and osteosarcoma is Codman angle and sunburst appearance. But for your practical practice, this may not be always true. Okay, so the size of the lesion, again, it's more important. Like if you have a huge soft tissue mass with very little bony involvement, it's possibly a soft tissue tumor into the bone. And if you have a huge bony component and small soft tissue component, it's otherwise. All right. So the other thing which the examiner wants you to talk about based upon your clinical examination is the staging. Okay, the staging was given by Enneking. He worked down in Florida. So remember that the Enneking staging system for tumors is a surgical staging system. It is not a prognostic staging system. So when Enneking first described it or published it, he wanted it to be used by the orthopedic surgeons to have an idea of what to resect and what to leave behind. Okay, but at the same time, if we want a prognostic staging system, we'll have to go into AJCC, which I'll describe later. So the first thing, the most important predictor of the survival in osteosarcoma is metastasis. Okay, so if you have an osteosarcoma, if it is metastatic, the survival rate drops from a classical 60 to 70% to 30%. So we are talking about 5-year survival rate. So the 5-year survival rate for an non-metastatic primary high-grade osteosarcoma of bone in today's era is roughly 60 to 70%, and which may be slightly low in some parts of India. And if you have a proven lung metastasis or any other metastasis, it comes down to 30%. Okay. And the second important thing is the histological grade of the tumor. Okay. For all practical purposes, most osteosarcomas that are kept in the exam are high-grade tumors. We generally tend to avoid keeping low-grade tumors, but that may not be the case. I will talk to you about one particular condition which can be kept in the exam. Okay. So between high grade has worse prognosis compared to a low grade. At the same time, it is also important whether the tumor is limited within a compartment or coming out of a compartment. So then it tends to define what do you mean by a compartment? So the compartment, when anything described, it is supposed to be limited by an anatomical boundary like a fascia or a sheath, and it has its own blood supply and nerve supply. But unfortunately, the way the human anatomy is in the body, you don't have perfect compartments everywhere. Say, for example, you have the adductor compartment or the medial compartment of the thigh. At some point, you will have some communication with the posterior compartment, and at some point, you can have muscles from the adductor compartment coming into the anterior compartment. So there are no true compartments, but these compartments help us to define in mind what are the facial layers that can help us in resecting the tumor. Okay. So similarly, when a bone tumor is there, when it is completely within the bone, it is intracompartmental. But when it has a soft tissue component, it is extracompartmental. But think about this way. Will we ever keep an osteosarcoma which is completely within the bone for your exam? We will never do it because there will be no examination findings positive there. So for most purposes, if you were to guess, like what will be the stage of the osteosarcoma that will be kept for your exam, it is stage 2B, because we usually keep high-grade tumors. We usually keep tumors which are arising from the bone and getting into the soft tissue. So if you say stage 2B, you are right majority of the times, but you must specify that you are talking about an Hennecking stage and not just any staging system. Okay, so the next thing to think about is the AJCC staging system. So why is this important? The AJCC staging system is the prognostic staging system which we use, or which is time tested and which is evolving. So as we understand more, this AJCC brings out various editions, and this is the latest editions of the AJCC staging system. So you can see for bone tumor, the cutoff is 8 centimeters, whereas for a soft tissue tumor, the cutoff is 5 centimeters. How do you remember that? You remember the letter B. The B looks like 8. Okay. So for bone tumors, the cutoff is 8, whereas for a benign malignant tumor, for a soft tissue tumor, the cutoff is 5 centimeters. Today we are talking about bone tumors, so I'm not going into soft tissues. So T1 and T2 are bone tumors less than 8 and more than 8. Okay, simple. T3 is a discontinuous tumor. So what do you mean by discontinuous tumor? It's a tumor with a skip lesion. Okay, I know I'm taking more time than what is scheduled, but it is very important to get through all these message across. So we are not going to be very time constrained today. So we will have the case and we should be good. Okay. So look at this MRI picture on the left. You can see a distal femur osteosarcoma, but you can see a small circular lesion on the top. So this is called a skip lesion. Okay. So whenever there's a skip lesion, it increases the stage, increases the T to a T3. Okay. So it is always important that whenever you order an MRI scan for a bone tumor like an osteosarcoma, you have to cover the entire length of the bone, and you just do not limit yourself just to the distal femur. It is a very common mistake. People say MRI knee suggestive of osteosarcoma, then they do staging workup and they go and do the surgery. And then when you finally come back, by the time you have done the biopsy and everything, the picture gets altered and we do not know how the tumor looked to begin with. Okay, so the staging system is lost and we are unable to guess a prognosis. N, as you all will know, like lymph nodes. So sarcomas typically do not spread to lymph nodes. Okay. So when you have a small lymphadenopathy in a sarcoma, please don't tend to say, sir, this is N1 because I can feel small nodes. Sometimes, especially in the Indian setting, it all can also be due to infections from the food or other. Some people tend to have small lymph nodes, which are usually not carrying the malignant cells. So you have to be careful. Although osteosarcoma and Ewing sarcoma and even chondrosarcoma has been described to go to lymph nodes, the metastasis rate is very less, 2 to 3% to the lymph nodes. Okay. So then the examiner will ask you, what are the tumors that can go into the lymph nodes? So this is usually a set of soft tissue tumors: synovial sarcoma, clear cell sarcoma, angiosarcoma, rhabdomyosarcoma, sarcoma, and embryonal sarcoma. These are the epithelial sarcoma, sorry. These are the sarcomas which can spread to lymph nodes. This is usually remembered by the mnemonic called the SCARE, S-C-A-R-E. Okay. So, and then you can see even in the metastasis, we define lung metastasis and other metastasis as different. Okay. So sarcoma, typical metastasis site is lung. And there's other common second most common metastatic site for a sarcoma is bone. Okay. So you can see that 4A is no lymph nodes and lung only metastasis. But if somebody has a lymph node like N1, the stage is not 4A, it's 4B. It is not even 3. So this is very different from a carcinoma, because carcinomas and melanomas tend to spread to the lymph nodes. So all this TNM staging system actually evolved from melanomas and carcinomas. Okay. So normally we tend to think if there is an N1, it is a lower stage. And if it is an M1, it's a higher stage. No. For bone sarcomas, especially osteosarcoma, M1A is 4A, but N1 is actually 4B. All right. Okay. So these are the typical typical 4 sarcomas which you can have in the exam: osteosarcoma, Ewing sarcoma, chondrosarcoma, and adamantinoma. So first important thing that can help you in the differential is the age of the patient. Okay. Although Ewing sarcoma has been typically said 5 to 15 years age group, it can happen usually mostly in the second decade, like around 10 years, whereas osteosarcoma usually like 13 to 16 years is the age group. Okay. But the age group is variable. You can say Ewing sarcoma 5 to 15 years, nobody will point a finger at you. But there are certain subtypes of osteosarcomas that you need to know, like paraosteal osteosarcoma can happen in the 3rd or 4th decade, and secondary osteosarcomas. Secondary osteosarcomas means osteosarcomas arising from Paget's disease or in a previously irradiated bone. They can have presentation around 60 years of age. Typically at 60 years, we are thinking about myeloma, lymphoma, and metastasis. But osteosarcoma is known to have a second peak. Okay. So the sites, as you all know, is for osteosarcoma is around the femur. You know that although remember, Ewing's is typically described as a diaphyseal tumor in many textbooks, but we all know Ewing's is a metaphysio-diaphyseal tumor now. It is not exactly the diaphysis, it is at the junction of metaphysis and diaphysis. So diaphyseal tumor is adamantinoma, metaphysio-diaphysis is Ewing's. And chondrosarcomas can be very, very slow growing. You have to keep it in mind, and same as adamantinoma. Okay. So the next thing examiner will ask you, okay, you said osteosarcoma. What is the type of osteosarcoma here? So he will say classify osteosarcoma. So this is how you are supposed to classify. I'm classifying osteosarcoma as intramedullary origin, juxtacortical origin, and secondary. Intramedullary origin is primary high-grade intramedullary osteosarcoma, which can be osteoblastic, fibroblastic, chondroblastic, or mixed. Or you can also get telangiectatic variety, which is like balloon-shaped or typically lytic osteosarcomas, and which can be very, very commonly confused with aneurysmal bone cyst. You can have a small cell osteosarcoma, which can be typically confused with Ewing sarcoma or other round cell tumors. You can have low-grade intramedullary osteosarcoma, which is very much fibrous, and it can be confused with a treated giant cell tumor like denosumab treated GCT, or even with a fibrous dysplasia or other fibrous tumors of the bone. Okay, so you must keep it. All you have to know is Osteosarcoma is a mixed basket, and this is how you should classify. What is juxtacortical? Juxtacortical means the medullary canal or the medullary marrow space is not affected by the tumor, but the tumor is on the surface of the bone. So in the surface tumor, you can have parosteal, periosteal, or high-grade surface tumors, okay? And you also can have secondary osteosarcomas, okay? So this is the typical picture of a parosteal osteosarcoma. This is not my picture, I taken it from the internet, okay? So what it looks like, typically looks like a myositis ossificans or a bony mass, which is kind of like, if you can assume like an orange is attached to the backside of the bone, how will it look like? So typically, so the important reason why you need to remember parosteal osteosarcoma for your exam is, you can give this entity as a differential diagnosis for osteochondroma. You can give this entity as a differential diagnosis along with myositis ossificans. Okay. So the important difference is, you can see that there is a small black line between the primary tumor and the bone, which is filled with some ossification here. So this is called a string sign. And when you cut this tumor, this is actually made of periosteum. So parosteal osteosarcoma is actually as if, which is just next to, what is para, which is next juxta. So it is just next to the bone and it is attached on top of the bone, okay? Whereas periosteal osteosarcoma, which is usually limited to the surface of the bone and which usually has a periosteal reaction. So you can remember, like, parosteal has got the string sign, periosteal has got this periosteal reaction, okay? And when you look at the X-ray, it is very hard to differentiate if it is an intramedullary or periosteal, and you always need an axial imaging like an MRI scan to differentiate. So, like, for example, if you look at this MRI scan, you can see that the marrow is primarily not polluted and the tumor is sitting on the surface, and it is almost encompassing, if you can think like a clock, it is almost encompassing from 7 o'clock to 4 o'clock position. Okay. The next important thing you need to remember in mind is, whenever you talk about a malignant tumor, you must also talk about some blood work and also staging workup. Okay. So when to do the staging workup? Okay. Typically in a center which deals with sarcomas, the staging workup might be done alongside biopsy, but sometimes it is good to do it even before biopsy if you have a very high index of suspicion. But if you are not sure whether it's benign or malignant, you can do it just after the biopsy. Okay. But the MRI of the local part has to be done before biopsy at all times. The MRI should include the entire length of the bone. It should include the joint above and below. And the typical staging workup for sarcoma is NC-CT chest. You do not need contrast for staging of a sarcoma. Non-contrast CT should be good enough. And for skeletal metastasis, you need either a bone scan or a PET scan. So the treatment for any osteosarcoma and Ewing sarcoma for your exam is neoadjuvant chemotherapy followed by surgery. So this is for a low-grade osteosarcoma, chondrosarcoma, and adamantinoma. Primary surgery is the treatment of choice because these are tumors which are known not to respond to chemo or radiotherapy. And definitive radiotherapy can be talked about only for Ewing sarcoma at inoperable sites, which we usually do not keep it for an exam. So don't tell the examiner, I'm going to give definitive RT for this patient. No. An adjuvant radiotherapy can be given when the margins are positive or very close. So I do not want you to understand this, but I just want you to get a quick picture of this. This is typically before the advent of chemotherapy, the osteosarcoma survival was 20%. So this is a Kaplan-Meier graph. You just follow the graph, and if you see like at the horizontally at the level of 20, that's where you stand there. And this is a paper by Dr. Marco, who is one of the pioneers of this limb salvage surgery. And it does not vary depending upon whether you do amputation or limb salvage surgery. So the most important point, if you do an adequate surgery, whether it is amputation or limb salvage, it does not matter for survival of osteosarcoma. And it does not matter whether you give pre-op RT or not, whereas in soft tissues, it does matter. So during 1974, you had back-to-back publications in NEJM where they found that certain certain chemotherapy regimens are giving rise to better outcomes. And these are some of the papers, and we have Norman Jaffe from MD Anderson here. So today what we do is something called a neoadjuvant chemotherapy. Neoadjuvant chemotherapy means when you diagnose osteosarcoma, you start the patient on chemotherapy, give few cycles of chemotherapy, do the surgery, and then do further cycles of chemotherapy. So the reason why it all started, you remember the three authors here: Gerald Rosen, he is a medical oncologist; Ralph Marco, who is the surgeon; and Andrew Huvos, who is the pathologist. So when they started this chemotherapy, they started, remember the primary word when they described is pre-operative chemotherapy. It was not neoadjuvant chemotherapy. And the reason they had to do it was, in that era, the implants were not readily available. It has to be made, custom made for the patient. And as you can see, it started with surgery was delayed in order to obtain a custom fitted prosthetic implant. So that's how the neoadjuvant was primarily conceptualized, because you had like 1 month of time before you can get the patient to the operating theater. They thought, why not we give chemotherapy first? And Dr. Who was a pathologist at the time, when the tumor came out, he started grading them as having good response and poor response, like 1, 2, 3, 4. Remember, did not give any numbers. It all came out later. Okay. So that's how the neoadjuvant chemotherapy started. And it has, I would say, revolutionized the treatment of osteosarcoma and improving the survival. So what is neoadjuvant chemotherapy? We have just described. And the advantages of neoadjuvant chemotherapy is, number one, it reduces the vascularity of the tumor. It might shrink the soft tissue component of the tumor. And it might also help you in achieve negative margins. Okay. So every patient with tumor of the extremity should be considered for limb salvage if the tumor can be removed with an adequate margin and the resultant limb is worth saving. There is no justification for limiting the limb salvage process based on the prognosis. It's very important for you to remember. So we talk about the three-strike rule, but which essentially means is the neurovascular bundle. Because the bone is always involved, the soft tissue is always involved. If the neurovascular bundle is involved, then we might have to do an amputation unless we are able to reconstruct it, especially the nerve. Okay. So if there any three of these key components are involved, the limb is probably not worth saving. So limb salvage surgery principles is again asked in the exam. We ask you, what do you mean by limb salvage surgery? The salvage limb should have acceptable degree of function and good cosmetic appearance, and it should have minimal amount of pain, and it should be durable enough to withstand the normal demands of the patient. Okay. So the contraindications are mainly neurovascular involvement, displaced pathological fractures can contaminate all the margins, and sometimes you can have fungating on infected tumors and recurrences of malignant tumors. So whatever is the contraindication for limb salvage surgery becomes an indication for amputation. Pulmonary metastasis and large tumor size are not contraindications for limb salvage surgery. Okay. So I have further presentation, but I do not want you to take all of this, but I'm just going to quickly share you some of the limb salvage techniques which we do or which you are supposed to know in the exam, and then we'll move on to the case presentations. Okay. So remember, like this is a surgical margin. For any bone tumor, we talk about intralesional margin, which is curating, which we usually do for benign tumors like a JCT, or marginal excision, which means removing the tumor around the periosteals, around the perilesional area. Wide resection when you do it with a cuff of normal tissue, and radical resection when you sacrifice the entire compartment. So the problem with this description is Henneking never described what is cuff of normal tissue, like how much cuff is cuff. So we have defined what we call as wide margin as adequate and inadequate. All you need to know is you should know all these margins are defined from the reactive zone. What is a reactive zone? It is a discolored area around the tumor, observable by gross inspection, that is composed of hemorrhagic tissue, scar tissue, degenerated muscle, edema, or tumor capsule. Remember, most malignant tumors do not have a true capsule. So what we are talking here is a pseudo capsule. Like, since the tumor is pressing on the soft tissues, it feels as if there is a capsule, but actually there is no capsule. Okay, so we are talking about pseudo capsule here. Okay, and all margins are calculated from the reactive zone. We have certain tissues which can be barriers and which can resist against tumor spread. So we have joint cartilage, which is the thickest barrier, which can equal to 5 centimeter of healthy tissue. Thick barriers can be 3 centimeter margins, which is like a iliotibial band. Thin barriers can have equal to 2 centimeters margins. In a typical high-grade osteosarcoma, we are expecting a 3 centimeter margin. But with effective preoperative chemotherapy, we can come closer to the tumor and we can do a 2 centimeter margin. But at the same time, if we have a recurrent tumor, we need to think about 5 centimeter margin. Okay. So what is the treatment? So you got onto this discussion and you're coming to the treatment. So the examiners ask you, oh, okay, doctor, sir, you did the preoperative chemotherapy, your response is good, you now want to do the surgery for this patient. What you have to do? If you think that the knee joint actually is not polluted and the quadriceps mechanism is intact, then you can do an intra-articular resection and do an endoprosthetic reconstruction. However, if the knee joint cavity is polluted by the tumor, how do you know the knee joint cavity is polluted or not? Number one, you look for joint line tenderness. Number two, you look for effusion within the joint. Number three, you look for fixed flexion deformity. Number four, you look for pain during range of motion. If these are there, then it means that the tumor might have invaded the joint cavity after crossing or from other sides, after crossing through the joint cartilage or from other sides. Then we have no other choice but to do an extra-articular resection. Remember, margins are very, very important in tumors. So then we'll have to do a knee arthrodesis with various reconstruction options. If the knee joint can be preserved, means the cartilage can be preserved, then you can do an intercalary resection where your resection just involves the bone and none of the cartilage, and you can talk about non-vascularized fibula or vascularized fibula or an ECRT. So just quickly through cases, this is an osteosarcoma distal femur, wide excision, endoprosthetic reconstruction. This is what you will get in the exam. This is an intercalary resection on the left side with a reconstruction with a fibula and allograft. This is a knee arthrodesis on your right side. This is the turnoplasty, which means like you resected the tumor of distal tibia, proximal tibia, sorry, and you cut the distal femur into 2 halves longitudinally, rotate the distal femur and achieve a knee fusion and remove all the cartilage. And this is what we call like ECRT, where we remove the tumor with a cuff of healthy tissue. Then we remove all the extraosseous component, clean the marrow cavity, pack the tumor in a sterile way, pack the bone in a sterile way and send it to radiation therapy. Give a very high radiation like 50 gray and put it back on the bone, on the body. And this is how the typical reconstruction looks like. And this is how the post-operative radiograph will look like. Remember, the ECRT bone, although it is the host bone, it will behave like a dead bone or an allograft. Okay. I'm sorry, I'm taking too much time, but none of these reconstruction techniques are perfect. Okay. With endoprosthesis, if you do an endoprosthesis in an 18-year-old or a 20-year-old, it is going to last like 10 years. So they are going to come back to you for further revision. If you do a knee fusion, again, it's not perfect. Patient cannot sit in a bus. They cannot sit in an Indian toilet. It's very, very, very functionally limiting. If you do like an intercalary reconstruction with the fibula, again, the fibula sometimes may not take up like the stresses of the femur, or even ECRT, it's a dead bone for life. So all the reconstruction options which we have in our kitty today has some problem or the other, but there is a future. Say, for example, if this is a distal femur osteosarcoma, the patient can grow their own bone. So this is a magnetic nail which we have these days, which is available in US, which is yet not available in India, or very commonly available, I would say. So the patient had a resection of the tumor, and they, with a very close thing, and they were able to save the joint cartilage. They're able to dock the tumor, and you can see that there is a lengthening happening from the magnetic nail. And this is the magnet in here. So once you have the lengthening all the way down, then you can do the bone grafting, fix it, achieve a union, and at the end of your reconstruction, you can see that both the limbs are pretty much equal, and you have your native bone. And once the implant comes out, you have your own bone. So this is, I think, it's going to be the future in India. Sometimes you have to know the chemotherapy schedule. For osteosarcomas, it is cisplatin and doxorubicin, 3 cycles before chemotherapy, before surgery. Then you have to wait for the absolute neutrophil count to be more than 2 and the platelet count to be normalized, surgery and post-op chemotherapy. For the Ewing sarcoma, you need to know about what is the drugs: vincristine, adriamycin, cyclophosphamide, ifosfamide, and etoposide. The total duration is 42 weeks, and the surgery should be performed after the first 12 weeks of the chemotherapy. I guess this is all I have for today. Differentiating a malignant swelling from benign swelling is the most important thing, and it should be a systematic approach. Okay, it is always important or safe to give differential diagnosis in the exam. Today, I'm not talking about radiology, but it will be covered, or it has already been covered in a different lecture. And these are some of my attendings today. I'm getting trained at Memorial Sloan, where James Ewings first described the Ewing sarcoma. So this is how the future of oncology is going to be. We'll have like people specializing, like one person here, like Dr. Prince specializes in regrowing the bones. Dr. Waindup does spine and pelvis. Dr. Morris does pelvis and pediatrics. Dr. Boland does cardomas. Dr. Athnasian does upper limbs. And Dr. Forsberg does osteointegration. And one final thing I want to say, if somebody is interested in pursuing a career in oncology, of course, Tata Memorial has, but we also have an oncology fellowship program running at AIIMS, and there are also fellowships in arthroscopy and joint replacement. It's an exam, it's a competitive exam which you have to clear, and the brochure is available on the internet. And this is my email address, venkatartha4@gmail.com. If you have any questions or if you want a copy of the presentation today, I'm happy to share. Thank you very much. So, Dr. Pratik, should we take the case presentation now? And then if we have, we can do the video.
Yes, sir. Yeah, I think that would be
presentation. See, I have taken plenty of time. I'm sorry about that. But for the case presentation, I'm not going to interrupt. And I believe Dr. Lau Kapoor and Dr. Pratik and Dr. Rishi would be able to take you through the case presentations. Okay.
Yeah. Thank you, sir. And
Dr.
Dr. Nishit, if you can share the screen.
I think I've shared it already.
Yeah.
Any
So Dr. Lau
questions
Kapoor is not able to join for some reason. And
no worries,
so,
you can take through.
But we have other eminent faculties actually. I can see Dr. Himanshu, I can see Dr. Janit Singh, I can see Dr. Rudra Pratap. So even they can participate in this and we'll have a good discussion.
Okay. So any comments or any burning questions before while Dr. Nishit is setting up, friends? So I'm available in the chat box. If somebody has got any questions, please feel free to post. Thank you. Over to Dr. Nishit. Welcome, Dr. Nishit.
Thank you very much.
I can't see your video, but otherwise I can hear you. No problem.
Yeah, go ahead, Nishit. No problem.
Yeah. So good evening, everyone. I'm Nishit Gupta. I'm a second-year orthopedic oncology fellow from Tata Memorial Hospital, Mumbai. Currently, I'm pursuing a fellowship in the orthopedic oncology, and today I'm thankful for all the organizers to give me this opportunity to present the case in this program. So moving on, I'll present the case. So a 43-year-old female, she is a homemaker. She had no comorbidities. She presented to us with a pain in the left knee for past 4 months, associated with a swelling in the left knee for past 4 months. She had no other history. The family history was negative for any warning red flag signs. She gave a history of the pain which was gradual in onset since past 5 months, which was moderate in intensity. It increased by activity, elevated by rest, without any diurnal variation, but it was gradually worsening. Similarly, the swelling which presented after the pain had started, presented 4 months back, it was gradually increasing in size, but it was not associated with any other complaint except pain. She had complained that she had a restriction of the activity of daily living because of this pain, and that's why she approached us. The past personal family history was negative. She was a post-menopausal female. The history regarding trauma, fever, everything was elicited about weight loss, any other pains or any other systemic illness. Everything was negative. On general examination, there was no significant finding on the general examination. Patient
Before
was
that-
Nishit, before you go ahead,
Yeah.
is there a
any-
significance to this pain and swelling? Like, does the order matter?
Yeah.
Uh,
So the
uh,
order does matter. If there's a long-standing swelling which has associated with recent onset pain, then and the history wise the duration is pretty long, then we can assume that it might be a benign swelling rather than of a malignant origin. But if the pain is the first complaint of the patient and it is associated with a rapidly growing swelling, which is associated with restriction of the movements, restriction of the knee joint, which is a fairly sudden onset, let's say in months' time, and it is progressive in a very malignant sort of disorder, then we are suspicious of a malignant activity rather than a benign nature of the lesion.
okay.
Dr. Rishi, do you want to ask anything?
No, basically, the patient has a history of pain for 5 months, followed by swelling notice for 4 months. Basically, looking at this, we're thinking of some sort of a malignant pathology, usually. But the age is 43. We have to think of some metastatic disease around knee. Unlikely, but then my second differential will be that only.
Yeah.
There is no.
So yeah. So for
why? Sorry to interrupt. Why could not be an osteoarthritis of knee in a 42-year-old female? Moderate intensity, increased by activity without diurnal variation, gradually worsening. Why directly malignant swelling?
Okay, but the problem is here the pain is associated with the swelling. Usually,
Could be sympathetic effusion of the knee joint.
can be possibility. But if you are suspecting of osteoarthritis pain, usually you other side of the knee is also usually involved most of the times.
I mean, with these two complaints, we should restrict still at a non-oncological swelling. We can get to that swelling being malignant
Agree.
or a X-rays and all.
Agree.
So both of them are right, I would say. Thank you, Dr. Himanshu, for participating. Nice to see you again. So as you said, we should have a broad differential at this stage. When you have a pain followed by swelling, we have a reasoning. So osteoarthritis, the pain typically happens in years. It is not usually months. So as I said, the duration before the patient usually comes to you, that's very important. Okay. And although you can see that the pain is increased by activity and elevated by rest, which is a mechanical pain. Okay. So typically tumors which are malignant can also give rise to rest pain. So Dr. Nishit, can you think of any bone tumor which may not have a swelling, but it can present with pain at rest?
Although this age is not typical for that, but osteoma in young children.
So can you also tell us, you did very well, but can you also tell us how can you differentiate an osteoma pain from a pain, say for example, due to arthritis or other symptoms?
Yeah, osteoma patients usually give a typical history that the pain is worsened in the night and it is relieved by analgesics, whereas completely relieved by the analgesics. Whereas the osteoarthritic pain, the patient usually gets a history that she will be giving a history that although she's taking analgesic, but it is not providing adequate pain relief to her, and it is over a period and it is worsening.
Great. So I believe the important question is, it is not only analgesics. Analgesics means it can be any painkiller. We are typically talking about non-steroidal anti-inflammatory drugs. You're right. See, that's what you meant in your mind. But what I'm trying to say, why is this happening? Say, why is an osteoma typically relieves to NSAIDs, whereas not so much with other drugs like, say, tramadol or opioids?
NSAIDs typically have an anti-inflammatory property also. That is the property which helps in pain, helps in relief of the pain.
Okay. And anything to do with the pathology of osteomas you can think about?
Osteoarthritis typically has a nidus, which leads to a reactive bone formation that leads to pain and causes a lot of inflammation in the surrounding bone.
Okay. So the nidus, which is the most important thing in an osteoma, it has got a target like there is a central radio density surrounded by radiolucency, and then you have typical periosteal reactions. I believe this will be covered or has already been covered in the radiology lecture. So this nidus has got 100 to 1,000 times more concentration of prostaglandins. There is a prostaglandin production which is happening within the nidus, as Dr. Nishit rightly pointed out. So that can give rise to pain, because we know that prostaglandins are pain mediators, and typically non-steroidal anti-inflammatory drugs are going to affect the prostaglandin synthesis. So that's why we have a very good response to non-steroidal anti-inflammatory drugs, but not so much to other drugs like even morphine or opioids or tramadol, which we typically think about. So when you talk about pain in your exam, as Dr. Nishit rightly said, you have to talk about the onset, the intensity. So there is an easier way to describe the intensity. We all know there is something called the visual analog scoring system. We should just ask the patient on a scale of 0 to 10, with 0 being no pain, 1 being very mild pain, to 10 being the worst, what should be the intensity of your pain? Okay, so that is a good way to ask that question. And the other things which we should be interested about while you are asking a history of pain, whether the pain comes during at night. So he has correctly said there is no diurnal variation, but pain can disturb the sleep. Okay, and are you currently on any painkillers at this point? And if you are taking any painkillers, how frequently are you taking? Are you taking 3 doses of ibuprofen every day? Are you taking just 1 paracetamol a day? How much? These are the other clues in the history which can help us understand. Then we also talk about radiation. I know it is not here in this case, but it is important to mention in your negative history. Okay. So what is radiation? You can have a pain at the local site, which is transmitted to other sites. So for example, in this case, there's a pain in the distal femur. It can radiate down the leg into the foot. What does it mean? It can be pressing on the sciatic nerve. It can be pressing on the common peroneal nerve. Okay. Or although it's not very typical, you can have pain at other sites like transmitted pain, which is not usually the case with sarcomas. Okay. And as he rightly said, the pain increased with activity. So it can be due to the mechanical pain by putting, so whenever there is a bone involvement by sarcoma, the bone is weaker. So when the patient tries to put weight on the leg, it can give rise to mechanical pain. The other problem is if the tumor could have involved the joint. It has penetrated and involved the joint cavity. So this can also give rise to activity-related pain by whenever the joint is loaded, there is a synovitis which is there, which can give rise to pain. Okay, so it's very good, Dr. Nishit. So do you, like Dr. Himanshu said, at this point, obviously we are dealing with a bone tumor case, so we should give a bone tumor the differential diagnosis. But it is a good way to think in your mind all the other conditions which can give rise to this pain. Can it be congenital? Hardly any congenital conditions. Trauma, yes. You can have stress fractures, or some stress fractures usually do not give rise to it, but sometimes patients can have myositis ossificans, which can present with pain and swelling. Patient had like an injury, which they will not tell you, okay? So, and patient had some massage by local therapist, which is common in India, and they can have myositis. Trauma, infections can give rise to this kind of a swelling and pain. But again, in India, we should always think about tuberculosis. Remember, tuberculosis is a big mimicker. Anything which can be neoplastic can be tuberculosis, or anything which can be tuberculosis should rule out neoplasia. Okay, yeah. So both ways it's important. Okay, so always this is a dictum which Dr. Ajay Puri and Dr. Manish Agarwal teaches. Like always, when you do a biopsy, send a small sample for culture, send a sample for BACTEC, send a sample for all your AFB stains. So it's a good practice so that you don't miss anything in your life. Okay, and obviously, trauma, congenital, traumatic, infective, inflammatory, degenerative, which is arthritis, inflammatory, you can have gout, you can have neoplastic conditions, which we are talking about today, or which you can, other thing is you can have iatrogenic conditions, And you should have this in your mind when you present in your exam. Like these, classify in your mind like all the different big areas. Can it be congenital, traumatic, infective, inflammatory, neoplastic? And you will have all the differentials. Okay, very good. So family history. So what are the important family histories you're looking for in a bone tumor case, Dr. Nishit?
So we are looking at a history of any other relatives being who have been treated in the past for a cancerous malignant condition or not, especially first degree relatives.
Okay, very good. So you can have first degree relatives with osteosarcoma. So the next question is, see, for an exam is like a tennis match. Okay, you pass the ball to an area, and depending upon where you pass the ball, you will get the question. So the examiner is not going to prepare for taking your exam. So whatever is going to come out of your mind, of your mouth, they are going to ask you a question out of what you say. So when you say there is no past family history, they will ask you this question, and they will ask you what are the syndromes, familial syndromes you're thinking about in bone tumors in general.
Yeah, in general. So we are first, which comes to mind, is Lee-Frommeni syndrome, which is because of deletion the P53 tumor suppressor gene. Second is the retinoblastoma syndrome. Along with that, Werner syndrome is also there, which is associated with osteosarcoma, increased preponderance of osteosarcoma.
Oh, very good. Okay, anything else you want to talk about, Dr. Sir?
Sir, another caveat that I would like to add, usually in exams, we get it as a swelling case. It is only after the history and the examination do we, boil down, or in fact, even after seeing the radiograph, that we come down to tumor cases. So right now, since Dr. Nishit has only mentioned the history, it would be prudent to treat it as a swelling and a pain around the knee joint.
Exactly.
And then go account, like as Dr. Himanshu mentioned, osteoarthritis, as you mentioned, tuberculosis. These are the differentials which will come to mind on the history basis. It's only later on that, so even in family history, what is the family history that Dr. Nishit wanted to elicit? Like, what was he thinking? So if you mention based on only on tumors, so that is on one diagnosis, but anything else on family history that you would like to see, like, any other person who's having tuberculosis, which could be, the cause. So that is important, not, as you mentioned in your presentation, not to jump to a diagnosis and just stick to it. You should have a differentials which you have to justify later on.
Oh, perfect. So I agree. So all these points which Dr. Pratik said is very important. Okay. So I would, I understand exam is like kind of, what do you say? It's kind of an acting. So you know what is the diagnosis? I know what is the diagnosis, but you have to presume that you do not know it so that you approach it in a systematic manner. Okay. So while it is very important, like Dr. Nishit said, Lee-Frommeni, and which is a P53 and other things, it is key to have a broader view. And for a bony swelling, as an examiner, I would also ask about hereditary multiple exhastosis. I would also talk about other bony tumors. Like when they ask about family history, they are trying to ask like, what are the things which are related to the bone, which can run in families, like in a genetic component. Okay, so we have bone tumors like fibrous dysplasias that can run in families. Okay, multiple fibrous dysplasias. Okay, and hereditary multiple exhastosis, as we talk about. So these are the things which you should keep in mind. Okay, Dr. Nishit, based on your history, do you think we have enough information to narrow down our differential, or do you think it is still broad?
Based on the history alone, I think we have a fair amount of idea that as of now we are dealing with a swelling around the knee joint, and the pathology is mostly a knee joint rather than a systemic disorder. And since the duration of the symptoms and the symptoms and the signs, for that matter, point towards more of aggressive pathology. But whether it is a infective or a malignant swelling, we cannot tell as of now.
You cannot do that. Perfect. Okay. So any other questions, Dr. Rishi, Dr. Himanshu, anything? With regards to
totally agree, sir. Without history, we have to keep some differentials in your mind, but then without seeing radiographs, all are the possibilities. But then,
Okay. All right, Dr. Nishit, do you mind going to the examination findings?
Yeah. So on general examination, there were no significant findings. Patient is a fairly built lady with and fairly nourished. There's no disorientation of time, place, and person. She had no systemic features suggestive of any chronic malnutrition or clubbing or cyanosis stress. There was no generalized lymphadenopathy or no generalized edema.
Okay, can I stop you here, Dr. Sab? So
Yes.
see, it is a good thing, as you all know, it is easier to say no significant finding. Okay, so the problem with this approach is no means anything. Okay, so rather it's a good way to talk about what are the things you specifically look for here in general exam. So you are talking about like there is no hair loss, there is no swelling at other body sites, there is no there are, like, say for example, if you are tuberculosis, you should always look for BCG scar on your left arm, like to rule out if the patient had BCG at all. So you should be slightly more focused rather than say no significant findings. We can talk about like what are the things we looked for. See, the examiner knows that it's not going to be present. All they are trying to understand from you is whether you thought about all those conditions when you presented. Okay, and also very important, like when you say pallor, so the next examiner will ask you, when will you expect pallor in osteosarcoma or any bone tumors?
Yeah, if the patient is on chemotherapy, then because the
chemotherapy is on chemotherapy. Then second, what else?
If a generalized systemic systemic metastasis, then the patient, because of the hypercaptability, she may have a chronic, she may present with anemia.
Patient having multiple metastases all over the body, they can give rise to, they can have pallor. Okay, can you have clubbing in osteosarcoma?
Sorry, sir, I don't know. I'm not aware of.
Usually, it's not associated with any bony lumps. But again, like if somebody has got a chronic inflammatory conditions, that can give rise to clubbings. But today we are not dealing with that. Okay, cyanosis, although it's a good thing for exam purposes, it is not so much related. Okay, and can we have icterus in an osteosarcoma?
Yes, it can be, because most of the chemotherapy drugs can degrade our liver functions, and the toxicity with the chemotherapy drugs can give rise to recurrence.
Perfect. Generalized lymphadenopathy, can it happen?
Generalized lymphadenopathy, as of now, if it's a lymphoma or a hematopoietic disorder, which is giving rise to skeletal lesion, then the patient might present with a general lymphadenopathy along with the bony pain.
Okay. What is the age of the patient you said, Dr. Saab? What is the age of the patient you said?
43.
Okay. So do you think lymphoma is a common diagnosis at this age?
No, lymphoma is not, but TB, yes. Even tuberculosis patients can.
I think, I'm not sure if Dr. Himanshu and Pratik agrees. So at 40-year female, if you have a bony lesion, lymphoma is a very, very common differential diagnosis, especially a non-Hodgkin's lymphoma, okay, NHL. B-cell lymphomas are very common to affect a female in a 40 years age group, and they are very common in a differential female. The only difference is lymphomas are a marrow disease, so they tend to affect multiple bones, and they are usually limited within the cortical limits. They don't give rise to soft tissue very soon, but that does not mean that it can never happen. If you leave a lymphoma for a longer duration, it can still have a cortical breach and a soft tissue extension. Okay, so I think generalized lymphadenopathy, it's very important in this case. Okay, and edema, that's up. Can you have edema?
Yes, again, if the patient renal functions or liver functions are deranged because of chemotoxicity and patient is developing some systemic failure, then he can develop edema. Isolated limb edema can be a predictor of neurovascular involvement also. If the veins are getting compressed and the distal outflow is blocked, then the patient may develop limb edema.
Perfect. Yeah. Perfect. Very good. Any questions, Dr. Rishi, Dr. Himanshu?
I would like to add one thing, sir. While we're doing general examination for doing bone tumors, actually you need to look for the skin also. Sometimes, we can see some cafe spots in sometimes associated with polyostotic fibrous dysplasia. One thing is that, and always look for the nail changes, as some patients who are on achieving neoadjuvant chemotherapy or adjuvant chemotherapy, you will find some nail changes in those patients also.
Very good. You must think about cutaneous markers for bony swellings. Okay. So the cutaneous markers, as Dr. Rishi rightly pointed out, is café spots. So remember, as I said, if you say café spots, then they will ask you, what are the differential diagnoses for café spots, Dr. Nishit? Can you think of some things?
So one is polycystic fibrous dysplasia, another neurofibromatosis.
Okay. So neurofibromatosis and café spots and polyostotic fibrous dysplasia, café spots, do they look similar or there can be some differences?
No, the margins of the differ in café of the associated neurofibromatosis and polycystic fibrous dysplasia. The margins are irregular in neurofibromatosis, where there are smooth margins in the polycystic fibrous dysplasia.
Okay. All right. So do you have like any named appearances for this? Like how they describe the margins? It's very good. See, we are taking the discussion to a next level. So this is like, say, for example, if you did not do the long case well, if it can very commonly happen, if you have a keep case, the discussion may not go well. Okay. So these are the questions the examiner will ask you to give you a pass. If your long case did not go well, if the examiner is asking you questions like this, how will you differentiate neurofibroma question? See, as an examiner, we try to give you every opportunity to pass the exam. Okay. The examiner never sits there with an intention to fail you. Okay. So it is the candidate who presents so much opportunities for the examiner not to give you a pass. Okay. So there is a typical description of coast of California and coast of Maine, which you can read in Robbins if you have time. So this is differentials. So when you think about polyostotic fibrous dysplasia with a café spots, what is café au lait? Can you say like it is?
Coffee like.
Yeah, it is coffee. Coffee means coffee. Or lait. Lait is milk. Okay. So it is as if a coffee powder is sprinkled on a milk. You have a tumbler of milk and you sprinkle coffee powder on it. How does it look like? Something similar. Okay. So what else will you expect in a polyostotic fibrous dysplasia? Apart from café spots and multiple fibrous dysplasia in the bone.
Precocious puberty. If she is a female, she will present with symptoms of signs of precocious puberty.
Okay, so you are talking about which syndrome here?
McCune-Albright syndrome.
Perfect. Okay, so if you give if somebody tells you McCune-Albright, it's like you are definitely passed. That table you have passed. Okay, so because you have knowledge. Okay, so McCune-Albright, apart from precocious puberty, it's an endocrinological abnormality. It can also involve thyroid abnormalities. It can involve growth hormone abnormalities. So you can have other problems as well. All right. Okay, we can go into it later. Go to the local exam. We have like 5 minutes, I would say, 5 to 10 minutes. We can quickly.
So before we go ahead, I think it's for the other delegates. Usually these cases come as short cases. Yeah. And in that, they directly jump to the local examination. Now, Dr. Nishit is presenting this as a long case. And that's why we need to cover all these aspects of general examination as well.
Yeah.
So Dr. Nishit, please go ahead. Yeah.
Perfect.
I would like to finish within 5 minutes. So
no, take your time. See, Dr. Nishit, no pressure. Whatever you can present, we can do today. That's it.
Yeah.
Okay. So on local examination, we are expecting the area of interest is the left knee and thigh of the patient. On inspection, there is a single globular swelling in the left distal thigh and knee with indistinct borders. There are no overlying skin changes, no dilated veins, no signs which indicate of an infection. Although there is a significant finding of an enteromedial scar of about 1 into 0.5 centimeter present on the enteromedial aspect of the distal thigh of the patient, which is overlying just overlying the swelling.
Perfect.
Okay.
So it is very important.
Before you go ahead, Nishit, you'll have to explain the significance of each of them. Like, when you said single, so then when do you expect multiple, and like examples of that? And if there are changes, as you mentioned, distal dilated veins. Yeah. So what is the significance of that?
Yeah. So a single swelling, one of the knee joint is the most common site for malignancy that include benign and malignant. In benign swelling, the most common disorder of arising of the bone is osteochondroma. So healthy multiple exostosis might present with multiple globular swellings, which might be arising from distal femur, proximal tibia, as well proximal fibula, and the knee will be deformed. It might have a varus or valgus component. Along with that, the multiple globular swellings which will be there, which will be arising out of the bone. So that's why we have to rule out whether any other joint or any other bone is involved along with the primary bone. Globular swelling denotes that it is being and the margin is smooth. It is being covered arising from the deep surfaces, and the margins are smooth. So any chronic one of the differences is osteochondroma surface, because the cartilaginous cap can be irregular, so it can give rise to a lobulated feel, and the appearance might be lobulated, which can give rise to multiple lobulated lesions.
So what is the common test to do if to rule out whether it is arising from deep surfaces or is it superficial?
So what you do is you tighten the muscle compartment from which is area of interest. So in this case, in the lesion arising from the anterior aspect of the thigh, so you have to tighten the cortices and see whether the swelling is getting more prominent or whether it is getting indistinct by tightening the musculature. So if it is getting more prominent, then most probably it is arising superficial to the muscle. If it is getting less prominent, that it is arising deep to the muscle.
Yes.
So other things which we should say as negative history also, there are no dilated veins. That's very important. Okay. So typically we would say inspection from the front, inspection from the side, inspection from the back for a swelling of the distal femur or a distal thigh. So I would say you should also think about site, size, shape, surface, and as you rightly pointed out, your borders. And you can say like overlying skin changes means everything, but you should also talk about like specifically what you look for. You look for redness, whether the skin is glistening or shiny, or whether there are any ulceration or fungation in the skin, isn't it? That's what we are trying to think about in our mind. Okay. And when we talk about the scars, it's very important. As you rightly said, there's a scar. It's also important, like whether it is healed by primary intention, secondary intention. And the scar can be due to many things. It can be unrelated to the trauma. It can be unrelated, like due to a trauma. It can be due to a biopsy. Or it can be due to a previous surgical intervention by somebody else. Okay.
Yes.
So it's also
And
important.
I think also the attitude of the limb in which it is examined.
Yeah.
Whether there is
Yes.
deformity.
Perfect. Yeah, attitude makes importance. We should talk about like if there is any gross wasting of the quadriceps. You are doing very good. See, these are very small points. See, the exam is a very basic like exam. It's like an MBBS third year or a final exam. Okay, but this is what the examiners see. For various reasons, we have not updated our exam format. So these are all the examiners are trying to ask you about. Okay. Anything else, Dr. Himanshu, Dr. Rishi?
Yeah, whenever you are seeing inspection, as you already mentioned, wasting, you have to look for wasting also, and you have to look for the significant, whether there is any edema in the distal part of the leg or the extremity is there.
Perfect.
Because it also signifies some significant venous compression or something like that.
Okay, perfect. All right, next slide, Dr. Nishit, please. Thank you.
Yeah. So on palpation, I confirm my inspectory findings that there is a single globular swelling which are from the it is located in the area of distal thigh and the knee. There is no localized warmth or induration. The size of the swelling is approximately 10 into 8 centimeters, or the margins cannot be appreciated. The swelling is tender, it is hard, it is a non-compressible swelling with a smooth surface and indecisive border. And it is extending from the distal knee to the approximately 10 to 12 centimeters from the joint margin in the thigh. It is fixed to the underlying bone, and there is no mobility in either in the mediolateral or the anteroposterior plane, and with a normal temperature, and the overlying skin is pinchable. The swelling gets less prominent when we flex the knee. So most probably the swelling is arising from underneath the quadriceps.
Okay.
Okay, so when you say hard swelling, we don't have to talk about compressibility because I don't know any hard swelling that can be compressible. But at the same time, he had rightly pointed out about the borders. And when we say fixed to the underlying bone, we also need to think about like whether it is arising from the bone or whether the swelling was arising from the muscle and getting fixed to the bone. And I think we covered a part of it during my presentation. And the skin or the swelling is pinchable. That is again very good. And when we talk about the location of the swelling, we also say like the swelling is present in the middle third, distal third, or junction of middle and distal third. So this kind of helps the examiner visualize in mind where exactly it's there. So
if I can allow, I mean,
please, Dr.
At this point, I think we are on the verge of completing palpation, and we should be very specific whether it is a medial condyle or a lateral condyle, because if we say extending from knee to distal thigh, I'm still confused whether the knee is involved or not. You can still palpate the condylar surface, or which side it is. Is it only on the anterior? Is it only on the medial? Which side it is? It is still difficult to appreciate from the findings. Is a global is involving the whole distal femur? Is it one side, a lateral side, medial side? We can still give out some clue at this point.
Perfect.
Yes.
Okay. So
you're doing very good, Dr. Nishit. I mean, I agree.
So to clarify that the swelling is arriving mostly from the anterior aspect of the distal femur, and the condyles and anterior part of the condyles are not palpable. Although joint line there is no tenderness, and the lateral margins of the condyles are palpable. But the swelling extending from the suprapatellar region up to approximately say 10 to 12 centimeters from the distal to the distal femur. Chiefly around the anterior compartment.
Yeah. So I think in palpation, you have to be specific with your measurements, because in inspection, you can give an approximation. But in palpation, I think you have to be specific about the dimensions if you can palpate it, that is. Otherwise, you cannot give a range while palpating.
If you are pointing out there is no local warmth and erythema, you don't have to mention again with normal temperature.
Another thing is a tenderness. While mentioning tenderness, you have to be very specific which part of the bone is tender, whether there is deep circumferential tenderness or only one side is tender. That has also to be mentioned. And on palpation, you have to be very, very specific whether the swelling is uniform in consistency or this has got variable consistency. Although you have mentioned this is hard consistent in consistency, I am assuming that it is uniformly hard. Most of the times malignant swelling, this word has to be mentioned. The swelling is not uniform in consistency, or the swelling has variable consistency.
But I think he's covered most of the points in palpation.
Yes.
So moving on further, the knee arm of the patient was reduced. She had no fixed flexion deformity. Although she had no fixed flexion deformity, the flexion was from the range of 0 to 45 degrees, and there was no extension present. The hip and ankle range of motion was normal. There was no distal edema or neurovascular deficit in the patient.
I think I did not understand this point. What do you mean by no extension?
No.
So the knee is coming to neutral, but if classical extension, at least 5 degree of extension is possible. But then in this
mean to say the knee is
fixed in flexion?
Hyperextension is not possible.
Talking about hyperextension, doctor. Sir.
Yeah.
Flexion 0 to 45 means that knee is coming to neutral.
It is coming to neutral.
Normal knees
not
we can. Normal sometimes we can have hyperextension.
So maybe that is not the correct way to express it.
Yeah, because then I feel that the knee is fixed in flexion or he has a flexion deformity.
Yeah.
Okay.
So when you mention that the range of movement from 0 to 45 degree, I think that explains it. And you can mention no hyperextension. I think that would be the way to go.
Okay.
Yeah. I mean, agree. Okay.
Yeah.
So based on your exam, Dr. what are your differentials?
So to summarize, she is a 42-year female who has a recent onset pain and swelling in the distal thigh, associated with the swelling in the distal thigh and knee with limited range of motion. And the systemic examination, we are not able to find out any other symptom, any other cause of the swelling. And it appears to be a localized swelling, localized pathology. Although there are no signs of infection or signs which point towards tuberculosis infection or chronic infection. So I would like to, but because of the small duration of the symptoms and signs and associated with it, there's a hard bony swelling, which is confirmed by my clinical finding. I would still like to give a diagnosis of malignant lesion. So my first difference.
It's a malignant lesion.
Sorry.
How do you confirm that it's a malignant lesion at this point? You can say a primary neoplastic lesion.
Yeah, sorry. Primary neoplastic pathology. Sorry.
Also, do you have any from your history or examination? Is there any sign of pathological fracture?
No, there is no sign of pathological fracture from my history.
Because you've not checked for any irregular movements or loss of transmitted movements or something like that.
So, as per my diagnosis, we are dealing with the primary neoplastic pathology of the left district.
Okay, so I agree that this has to be tested in a patient when you are talking about abnormal movements and loss of transmitted mobility. But as we all know that this happens more in non-unions rather than in a tumor with a pathological fracture, because sometimes when we deal with this malignant swellings, it is also very important not to create a pathological fracture during the exam.
Yes.
Okay, so you have to be very, very gentle with these patients. The lesions, especially if they are lytic, we do not know because we have not seen the X-ray. So especially if they are lytic, when you try to do a torsional or a twisting movement, see, when you mean by transmitted mobility, what you're trying to do is you're trying to do a log roll of the femur from the distal side and trying to feel for the greater trochanter. So you're trying to create a torsional movement in the femur. Torsion is very, very, very significant. It can give rise to a fracture, pathological fracture, plus torsional deformity. So you have to be very gentle. You can say, if you say, sir, I have not looked for transmitted movement.
That would be a better option to say.
Because I might risk a pathological fracture.
Yes.
Okay.
I think Dr. Nishit did a very good presentation today. We had other interesting things, like we had a video demonstration. We also had some cases to discuss, but I think due to paucity of time, we won't be able to cover those.
I think Dr. Nishit can just go through, finish his slides, because we can just complete the imaging part of it, and then probably
we can do that. But supposing if I don't get to talk, I would like to definitely thank the Sarcoma Education Foundation team, Dr. Prateek, for all the hard work, and Dr. Rishi and Dr. Himanshu for the participation. Go ahead, Dr. Nishit. You can just show the X-rays and you can wrap up or whatever you feel like.
Okay. There's the clinical images of the patient with the endomedial scar, which is more probably the bias. And this is the X-ray of the patient on presentation. So it shows a dense sclerotic lesion in the distal femur, with more probably a biopsy tract visible in the distal side of the femur. And there is an overlying soft tissue component is also visible in the anterior compartment, which is extending in the suprapatellar pouch. Otherwise, there is no periosteal reaction as such. And looking at the lesion, dense sclerotic lesion with the matrix looks like a osteoid. So on an X-ray, I would still go with a differential with a diagnosis of osteosarcoma.
I agree, Dr. Sam, but at the same time, see, you know the pathology, I know the pathology, and we all agree. But see, for the exam, we should try to tend to be broader, like we should act as if we don't know it. Okay. So what else can you think in your mind? 43-year-old female.
Yeah, 43-year female with a sclerotic lesion at distal femur with a soft tissue component. First thing which will come out, which is pop out of my head, it will be a metastatic lesion from a undiagnosed breast carcinoma.
Yeah, exactly. So that should be a first thing. Second thing, will you think of lymphomas? Can this be a lymphoma?
Yes. Second thing will be a lymphoma, which also presents with a dense sclerotic lesion in the bones.
Okay, and there is another entity called limited Paget's disease. Although it's not associated with a soft tissue swelling, but if you just look at an X-ray like this with a dense sclerosis, that again can come to your mind. Okay, and anything you want to add, Dr. Rishi or Dr. Himanshu or Dr. Prateek, like what else can come to your mind? So
in this case, sir, what would be the order of differentials to give? Because at this stage, if you say osteosarcoma first, that doesn't sound correct. So would that be an order for these differentials?
Okay. See, the question is, what we are trying to ask is, are we sure it is osteosarcoma? There are many things which are
Yeah.
fit. Number one is the age.
Mm.
Okay. And number two, the sex, although it's not very important, but we all know, like females, GCTs and parosteal osteosarcomas. Say, for example, if we showed an X-ray of a parosteal osteosarcoma, I would have said like it is more fitting into the picture. Okay.
Mm.
This is an unusual case, and that's the beauty of oncology, that we always have unusual presentations every time. Okay. Sometimes low-grade osteosarcomas can have this kind of a picture. So it is very important to, it's more than the order. It is very important to say the examiner, while I think it is an osteosarcoma, but I also think can be other things. Like, as again, the same thing, congenital, traumatic, infective, inflammatory, neoplastic. So within neoplastic, what are the other things? So the same order, if you keep in your mind, you can arrive at few differentials. And you have to tell the examiner that these are the differentials that are running in my mind. And although the soft tissue component is present there, but it's not like very apparent. It's not hitting at your eye, the soft tissue component. So, and the typical Codman triangle or sunburst appearance is not available here, isn't it?
Yeah.
So the whole idea is you can keep with whatever differential you keep at it first, both are seems right, because 43 years you can keep metastatic disease as a first differential, or looking at the after looking at the X-ray, osteosarcoma can be a first differential. Other possibilities are there, but then low grade infection like the osteomyelitis of Gary is also a differential at this point. That also we need to think when there is a sclerotic lesion like this. Other conditions.
Dr. Nishit, can you think of chondrosarcoma here? Can this be a chondrosarcoma?
Although the age is there, but radiologically it is not a chondrosarcoma, because the matrix of the lesion is purely sclerotic, and it is more of osteoid formation. So chondrosarcoma is ruled out based on X-rays, based on this X-ray.
So when you say osteoid formation, see, for a general orthopedic surgeon or a PG student, everything is white. Okay. So how do you differentiate between a chondroid calcification and an osteoid formation, or how do you explain it to a general examiner?
So a chondroid calcification will be mostly a fluffy calcification with a ring and arc pattern, and whereas osteoid bone will be dense bone, which will be like lobules of bones which are formed in the soft tissue or in the bone, in the lytic region of the lesion.
Perfect. Okay, so I will give you another trick. You can think about this way. See, the main difference between both chondroid and osteoid have calcium deposition. Okay, that's why you are getting it white, right? Yes. But at the same time, the difference is the osteoid has got collagen within it. The osteoid. Okay, so if a painter has to paint this picture on a board, you must think about. Imagine, like if he is going to use the body of the brush to paint it, like how it is wavy and thing, it is more like an osteoid. But if he's going to use a tip of the brush to paint it, like multiple punctate spots, which you have to put using the tip of the brush and which coalesce to form rings and arcs, then it is possibly a chondroid calcification. So you need to imagine it that way, like if you can paint it with the body of the brush or a tip of the brush. So that gives the differentiation is whether there is collagen within the matrix or whether it is just a chondroid matrix mineralization with the punctate calcifications. Okay, go ahead. Anything else? Yeah, you got the MRI, perfect. So as we said, like the MRI, as you all see, it covers both the hip joint as well as the knee joint. So it's very important. It's very important that you cover both the joints, entire length of femur. Go ahead, Dr. Nishit.
Yeah, so the lesion extends in mostly in the distal femur with the extra soft tissue component extending in the involved in the vastus intermedius muscle. The rectus appears to be free. The neurovascular bundle appears to be free. It is on the T1 it is hypointense compared to the hypointense, and on the contrast there is a uptake with the central necrotic area which show lack of uptake. Perfect.
So can you show us where is the rectus, where is the neurovascular bundle in the axial view?
Yes, sir. So this is the rectus muscle, and this is the veins and artery, and this is the sciatic nerve.
Perfect. See, that is a reason why Dr. Nishit said rectus is free. Okay. If you remember the algorithm, I said, if you can save the quadriceps mechanism, you can do a knee replace or endoprosthesis. But if you cannot save it, you have to do an arthrodesis. So if you understand anatomically, rectus has got its own subfacial sheath. So it is in a slightly different compartment compared to vastus intermedius. So although the lesion is involving the vastus intermedius, or maybe even the vastus medialis, you can at least save the rectus so that the quadriceps mechanism can still be functional and working. Is it, Dr. Saab? Am I right? That's why you said rectus?
Yes, sir.
Perfect.
That was the
So,
intention.
do you think the joint cavity is involved here, or joint cavity is polluted here?
No, sir. Although it is not appearing, but there is no effusion as such in the this thing. There's no effusion in the knee joint which can denote a joint cavity pollution.
Perfect. So you are planning what kind of a resection here?
So we are planning for, since the whole knee joint is involved and it is extending. It is a metaphyseal diaphyseal lesion which is extending in the epiphysis. So I am planning for a neoadjuvant chemotherapy. But before that, we have still not done a staging biopsy as well as staging for the patient.
Go for it.
All this is radiological diagnosis.
Go for it.
So moving on, we did a biopsy for the patient via the intramedullary approach, and it turned out to be conventional high-grade osteosarcoma with the chondroid differentiation. For staging, we did bone scan and non-contrast CT with thin cuts, and both revealed that it is a non-metastatic osteosarcoma. So the patient is planned for neoadjuvant chemotherapy, and subsequently, based on response assessment, most probably she will go for a. We are planning for an osteoarticular resection and endoprosthetic knee replacement for the patient.
Yes. So I think here, Nishit, here you may get questions on the type of biopsies, and why needle biopsy is preferred, and the incidences of tract contamination with needle biopsy versus an open biopsy.
Mm-hmm.
And then the other question obviously will be on the osteosarcoma and the types that you have mentioned. Now that you have mentioned conventional high grade, so logically the next question would be, what are the other types of osteosarcoma that you know of? And when they mean by chondroid differentiation, does it change your management or does it change your prognosis? So these are the other questions that probably you can expect if your case reaches up to this level and this point.
Yes.
Yeah.
Okay.
Perfect.
So, okay.
And then
yeah. Sir, sorry, I couldn't get you, sir.
I'm trying to ask, are there any other questions?
I think he finished it well.
Thank you, Dr. Himanshu. Dr. Rishi, you want to have any comments?
Nicely presented case, sir, for exam. But then depending upon the time, examiner can ask many questions regarding management and all. But clinical examination as a long case, he has done well.
If you follow the Sarcoma series, Sarcoma Education Foundation series, they cover all the topic. They cover biopsy, they cover radiology. So I think, like, for people who don't have time to visit books, if you just go to these presentations and lectures, because this is all by renowned experts from the country, and they have put in hard work to prepare for this, and Dr. Pratik has put in his efforts to organize this. Are these recorded lectures available for viewers, Dr. Saab, somewhere?
So not right now. Right now, we want them to attend maximum webinars, because once the recorded ones are available, they may not attend the live sessions. Okay. So we are waiting for that. And I think, Dr. Nishit, thank you for presenting this case. As sir mentioned, it was a short notice, but still you did a good job. So thank you for that. And thank you to Dr. Venkatesan for taking time out from his busy schedule from New York to present this. I'll take this opportunity to give a brief about the next session that we'll have, which will be moderated by Dr. Himanshu and chaired by Dr. Mandeep Shah. This will be on management of bone metastasis, and that will be on the second Saturday of May. So kindly do register for that. Another small announcement is actually regarding the previous quiz winners that we had. We have tried to contact the Feb and the March quiz winners, and some of them have not replied back. So this will be like the last warning to them, or last notice to them to get in touch with us. Otherwise, we'll have to either forfeit the prize money or give it to the next person. So before the next session, kindly do get in touch with us so that we can allot the prize money to the deserved winners. And I think with that, I think we can call it a wrap, sir, for this session.
Thank you.
Yeah,
Thank you,
unfortunately,
Venkateshan, for making out the time for us. It was a really
Yes.
good presentation from your side.
yes, thank you, sir. That was very extensive and a good presentation. Unfortunately, Dr. Love Kapoor could not join us, but thank you to the others who contributed, Dr. Ishiram, Dr. Imanshu, and also to the delegates.
You can include him for the upcoming. We have three more sessions, so you can include him in any of them.
Yes. We'll try and get him in that.
Thank you.
Thank you,
Okay,
sir.
thank you
Thank you
all.
very much. Thank you for the opportunity.
Thank you, Nishit. Yeah.